So our next session, I think, is going to be one of the most exciting talk because everyone here is going to know the H. pylori infections very well. And right now, we're going to have a new Maastricht 6 consensus, and the speaker is going to be Professor Peter Malfertheiner. I believe that no need for very much introductions about Professor Peter Malfertheiner. Today, he's going to join us online about let me know the importance of the Maastricht 6 consensus for the treatment of this important bacteria. Professor Peter Malfertheiner, please.
Hello, good evening, everybody, or good morning. I'm speaking from München in Germany, and I have the pleasure to share with you some of the last Maastricht Florence consensus statements that we worked on in our conference in Florence, September last year, and it was recently published in GATT. I have no special conflicts beyond the ones here. The presentation, very briefly, will deal with the meeting conceptualization. I selected a few key statements and then will speak more about gastric cancer prevention and novelties on treatment. Altogether, 87 questions and statements were tackled. The team was international with 42 experts from 29 countries. There was a very good representation from Asian countries, many friends, of course, but all people who have dealt with H. pylori for many, many years. We re-emphasized this important concept of H. pylori gastritis as an infectious disease. This is the Kyoto, driven by Professor Sugano's conference now 6 years or 7 years ago. And since then, we continue to educate our colleagues and the physicians that it's a difference between infection and an outcome of this infection, because the outcome of infection can already be defined as a disease, because we know that an inflamed gastric mucosa is obviously associated with structural and functional disorders. Just one aspect, aspirin and non-steroidal anti-inflammatory drugs increase the risk of peptic ulcer disease and complications. This has been, of course, an important statement, as it implies that one should proactively search and treat patients, especially those with comorbidities who need or are in continuous need of these drugs, and then eradicate Helicobacter is there in order to render the mucosa less vulnerable. There is an important challenge, especially in patients who undergo dual platelet inhibition, as in the case of acute myocardial infarction, when stents are placed, and then these patients require ongoing PPIs in order to prevent the incidence or the risk of apogee bleeding. There are data to support that concomitant infection with H. pylori and antithrombotic therapy increase the apogee bleeding significantly. And there is a very important large trial that has been initiated in the Nordic countries, specifically in Sweden, in Europe. And the idea of these researchers is that they will, by having a patient entering with acute myocardial infarction, undergoing stenting, that he gets also a test for Helicobacter pylori, and in case they are positive, they receive eradication therapy. And moving to cancer, H. pylori infection is the primary etiologic factor for gastric adenocarcinoma, but includes also the proximal gastric cancer. most of the papers that you read, you see it's related to distal gastric cancer, but the definition of the gastroesophageal junction, which has recently been also a content of an international consensus in Kyoto. The reference is shown here. H. pylori infection plays a relevant role as the etiological agent in a subset of patients with adenocarcinoma at this junctional zone. So we have two distinct etiologies. It is reflux disease on one side with the, let's say, the worst outcome, Barrett adenocarcinoma, and H. pylori. And of course, in this region, both of these agents can also coexist and increase the inflammatory reaction of the region. Now, gastric cancer, and it's certainly not me from the European perspective to bring something very important to you in Asia, where especially in Japan, South Korea, and also in China now, and Taiwan, the main studies have been performed to prevent gastric cancer. There are ongoing studies. There is something already that happened. The importance is from this epidemiological data that I'm showing that you see the increase in gastric cancer occurs above the age of 55 usually. And so a person at that age need to be considered as a vulnerable person in the presence of H. pylori infection. The strategies are several. This one is the so-called mass eradication, which was really a pioneer study in the Matsu Island, which confirmed that a study of these patients testing, eradicating, will be possible to drop dramatically. And it was shown 53% reduction in gastric cancer incidence compared to historical control is possible with non-invasive combined with endoscopic testing, depending on the clinical scenarios. Huge study we are all expecting, which could be or will be the biggest one, is the Linku trial in China, and it's on the way. Now, important thing is that we in Europe, with a lower incidence and prevalence of gastric cancer, may still consider something that has been, I would say, just not taken as an option, and that means to screen for gastric cancer prevention simultaneously when we perform the highly advertised colorectal cancer screening by colonoscopy. So there are several approaches. There's also some EU-sponsored project now moved ahead, and this can be offered also on a personal level to patients, to subjects that present for preventive medicine, that we offer them colonoscopy with non-invasive testing, and non-invasive testing could be initiated with pepsinogen 1, the ratio pepsinogen 1, pepsinogen 2. This is, I think, a very practical clinical way to move ahead. So the other aspect I'm sharing with you is the news on treatment. We came up with 17 statements, many parts of the world concerned with the high clarithromycin and levofloxacin resistance, both are very effective antibiotics in combined regimen with acid inhibitors, and by having this increase, we are losing the efficacy of the conventional triple therapy. I know that in many Asian countries you use the 7 days. In Europe, we have for long now moved to a 14 days treatment. We are not particularly concerned, of course, with metronidazole resistance, as we know that especially by using bismuth, this can be overcome, and there is no concern almost with amoxicillin, tetracycline, and rifabutin. In the European experience on more than 1,000 adult patients, we have moved up now in the critical zone with clarithromycin resistance. You can see the data here, 21%, and even the so-called critical cut-off of more than 15% for levofloxacin. And I mentioned the less or lower importance of metronidazole resistance. Now, the big question is, why is this so? And it's interesting that the consumption here, briefly, the evolution over a period of 20 years, you see clarithromycin doubled, clarithromycin resistance doubled in this period of time. But the reason for an increase of macrolide resistance is shown here. Italy on top in this multi-center European study with more than 30%. And you see also the consumption of different macrolides in this community. The Italian community is much higher than the one in Germany. And in fact, the resistance of clarithromycin resistance of Helicobacter is at least 10% lower, but also the intake of or consumption of daily amounts is much lower. The dramatic decrease in H. pylori eradication rates of clarithromycin containing regimen is counteracted by the fact that in Asian countries, starting from Japan, you had the introduction of a PCAB, and you have it now, other PCABs in other regions. And if you look specifically the reduction in efficacy of PPI triple from 2000 or pre-2001 to post-2015, if the PCABs were not taken into consideration, we moved down to, I would say, a non-acceptable performance of these eradication therapies. Consequence is that if we want to use clarithromycin combined regimen or based regimens, we require susceptibility testing. And there are now kits for antibiotic resistance testing in house PCR-based and commercial techniques. If I am allowed to give you a personal view, the gastroenterologist, especially in dedicated centers, should use a PCR-based molecular susceptibility test in order to at least surveil the region. And as we also learned, this molecular test can also be performed in stool. So the statement which has been the most debated is, how should we first approach a patient with Helicobacter pylori gastritis or complication? It is reasonable to recommend the susceptibility tests, molecular, or of course the more cumbersome culture, before prescribing first-line treatment. However, the generalized use of such a susceptibility-guided strategy in routine clinical trial is not, here it's written, remains to be established. Graham Moss and Moss published, that you can proceed according to the availability or not. If you use an empiric treatment, you see on top 3 options. You cannot empirically use all the others that were crossed out. And you have, of course, also in the unknown situation, certain options, but as I mentioned before here, I would not agree with these proposals because we need also for levofloxacin to know the resistance. We are often not in the possession of laboratory facilities. I mean, the mass of doctors treating Helicobacter pylori. And therefore, we have to consider a treatment which, in the absence of a susceptibility-guided strategy, is effective. And if we look at the available data shown here, many again coming here also from South Korea, from Spain, but from China, that you have no advantage in this region. And I show you now the reason. Because if you use a very effective first-line treatment, like in this case, an empirical bismuth-based quadruple, and compare it with a tailored therapy after resistance testing, in a population with high clarithromycin resistance, more than 30%, the PPI-based quadruple with bismuth in the empirical group was not inferior. You see that the data are, you can say, almost equivalent. I wouldn't share that 10-day empirical was more effective. It's not. It's also not safer, I mean, at least to my judgment, but it may be less expensive depending on the molecular test that you use. What is the Maastricht recommendation? Low clarithromycin resistance is absolutely a chance to use both these treatments, bismuth quadruple or clarithromycin triple. If this fails, we have a succession of options. I would underline again that levofloxacin is a sensitive antibiotic with resistance issues. So in your region where you want to go to use levofloxacin, you should know how high it is. If the resistance is higher than 15% or unknown, then the first option is bismuth quadruple, because we do not incur in any problems using tetracycline, as we preferably recommend metronidazole bismuth and the acid suppressant. If you do not have this, it's certainly a more critical issue to use the non-bismuth quadruple, and there are now other options which are exactly at the stage where it could not be included as the first recommendation when it gets to regions with high clarithromycin resistance. If all this fails, rifabutin is the goal. Frequently, resistance testing is not available. We have another way to look at the eradication efficacy, because we just have to test, which is also like a commandment that you treat and test for the eradication result. And if you note that the patient is not responding to your treatment, it's obvious that there must be, among the possible other causes, certainly resistance playing a major role. So resistance data are required at the community. Take the opportunity to include resistance testing when you are performing an endoscopy. It's choosing first-line regimen, of course, will depend on where you live, depending on the resistance. So the local connaissance of knowledge of resistances is critically important. Gastric acidity is the new wave of options coming up with PCABs. If you don't have PCABs, but that's not the case in your regions, it's a case still in Europe where we don't have the PCABs, then we use high-dose PPI, which is proven to be more effective. But if you have potassium competitive, is what was first shown by Murakami, that you have, even in failures, even with high situation, and this was further confirmed by Professor Suzuki and colleagues, resistant strains are successfully treated, in this case with the PCAB dual therapy. And you see the dual therapy, although inferior to the triple, can still compete with the best triple therapies in the Western world. What to do if first line fails? I mentioned rifabutin. There is rifabutin-based triple. There's a new galenic formulation. It was published by Professor Graham and colleagues, 4 capsules every 8 hours for 14 days. What surprised me in this study is that omeprazole amoxicillin had such a low in its dual combination eradication success. This is strange, but in contrast to the US situation, where rifabutin containing regimen can be used in first line, in our regions, it's already Maastricht guideline, it's a third line regimen. The data from Professor Liu in Taipei, from Professor Chen, all show that you have a decrease in the diversity of the combination, independent of what type of combination you use for eradication, but it's a transient form. Also, the induction of resistance is linked to this. What about probiotics? If we know that we have, at least for a prolonged period of time, a change in the gut microbiota composition, which might be considered as a dysbiotic and vulnerable condition, then yes, there are certain probiotics that are effective. There are many data, many meta-analyses. It is possible with single strains, but it seems like multi-strain mixtures are except from the condition of Saccharomyces boulardii, more effective. So let me conclude. H. pylori treatment is challenged by high and continuously rising antibiotic resistance. Clarithromycin and levofloxacin, when used in eradication regimens, should be tested whether they work or not. There are now a plethora of molecular methods that can be introduced in the clinical setting. Still, this, for the moment, is not superior when you have a treatment that is not depending on clarithromycin or levofloxacin resistance. Antibiotic surveillance is essential. That's the least what you can do. So there are reference centers required, and the current information on the PCABs let us hope that in the future, with a fine-tuned dual treatment, leaving out a third antibiotic, could do it, or even a second antibiotic. Dual therapy is very promising, and the era of H. pylori and gut microbiota is something which I think should remain in the center of our intention, of our attention as well. And probiotics, that is my last statement, should probably be used in more vulnerable patients who suffer antibiotic complications or cannot tolerate it so well. So thank you very much. It's very sad I cannot meet with many of you. I have many friends in your part of the world. And also excuse me for being a little bit vague in certain selected statements, but I think it should encourage you to discuss and look out for the best solution in your areas to eradicate H. pylori in order to prevent all the possible tremendous complications such as cancer. Thank you very much.
Thank you so much, Professor Peter Malfertheiner, for your excellent talks.